Good evening to everyone joining us from across Canada. I'm Jennifer Jones, the CEO and President at Fighting Blindness Canada, and I'll be your host this evening. I'm excited to get to the conversation you've joined us for. We have this incredible group of really amazingly intelligent, compassionate, kind humans that are funny and are going to bring you a great conversation. But first, what I want to do is acknowledge that in Toronto, we are on the traditional territory of the Haudenosaunee and the Mississaugas of Credit First Nation. This land is also part of the Dish with One Spoon territory, a treaty between the Haudenosaunee Confederacy, the Anishinaabeg, and allied nations. And we have guests and community members across Canada. We acknowledge that the ancestral and unceded territory of all the Inuit, Métis, and First Nations people for whom this land is home. And now a big welcome to everyone for joining us to episode 2 of Fighting Blindness Canada's Accelerate Vision Health series. Tonight is the second of a 3-part web series designed to do a few things, and that includes celebrating the expertise we've built over the past 50 years through the investment in world-class research, putting the researchers and healthcare professionals who are at the center of our work in front of you, hearing the critical perspective of people living with vision loss, and lastly, sharing the trends and opportunities that are shaping the future of vision research and healthcare. As Fighting Blindness Canada is 100% funded by philanthropy, it's important that we thank everyone with us tonight for your support for the work that we do. I also want to thank the corporate partners of Accelerate Vision Health series, which would not be possible without their support. And those are the Ask and Answer partners, Dealey Group and Roche Canada, our virtual broadcast partners, Amgen Canada, Bayer, Heathbridge Capital Management, and our registration partner, that's Faulkner Eye Institute. Thank you to everybody for being on this journey with us. In our first Accelerate Vision Health episode, a few weeks ago, we talked to Dr. Ian McDonald and Dr. Matt Benson about the success they have seen in the inherited retinal disease space in the last few decades, and where they see the opportunities for innovation. For tonight's topic, the state of vision health, navigating eye care, we are delving into the health ecosystem and what it means to be diagnosed with an eye disease and navigate vision loss. We will be joined by 3 special guests who are 2 healthcare professionals and a retired psychologist who lives with an inherited retinal disease. There will be a chance for audience questions at the end of the program. Questions can be submitted using the Q&A button, or you can email us at info@fightingblindness.ca. So let's get to our expert guests tonight. And it's my pleasure to welcome Dr. Ed Glassman, a retired clinical psychologist who worked for 25 years at the North York General Hospital and Adult Mental Health Program, as well as seeing clients privately. He wound down his career teaching in the York University Graduate Clinical Psychology Program, and 25 years ago, Ed first noticed changes in his vision and was eventually diagnosed with cone dystrophy, a type of inheritable retinal disease. Dr. Anne Juricic is a low vision optometrist and a leader in the field of vision rehabilitation services for individuals living with vision loss. She has put more than 28 years of experience to creating the vision enhancing method for individuals living with vision loss, which focuses on vision health and vision solutions beyond the traditional. The Vision Enhancing Method Blueprint Mentorship Program for eye care professionals is also an important part of that program. Dr. Nirojini Sivachandran is a trained retina specialist. She obtained her PhD and her medical degree at the University of Toronto and completed her residency training at the McMaster University in Hamilton. Dr. Sivachandran practices the full breadth of medical and surgical retinal diseases with experience in complicated cataracts, and currently she practices in the community with the Toronto Retina Institute. So now that you know the expertise that we have on hand, we're really excited to have the conversation. And out of this is what you can take away. What your experience could be when you meet with a healthcare professional. As a patient, how best to advocate for yourself? What questions should you ask? What access to doctors might look like depending on where you live across our country? The importance of medical health for you and your family and caregivers. And lastly, the role that Fighting Blindness Canada has to answer some of these points tonight, but also after this the series wraps up. I'd like to start by opening it to Nero and Anna. When we were preparing for our conversation, one of the phrases that came up was that patient diagnosis is an art and a science. And I'd like to hear a little bit more about what does that mean for you in the experience that you bring to your patients every day. Nero, if I could start with you, it'd be great to hear a little bit more about how it is an art and a science for you every day.
Absolutely. Thank you so much. And thank you for the opportunity to talk about something that's very meaningful to me and, of course, to the Canadian community. So I think in medical school, there's like a little gloss over of the art of medicine. And there's like maybe a little small lecture on it. But it really, I think, speaks to who you are as an individual and how you communicate with those around you. So having difficult conversations, delivering diagnoses, and it really is an art because you have to sense where that individual is, if there's support with them in terms of family members in the room, um, giving that diagnosis when you deliver a news, like all of a sudden their headspace, they're completely in a different world, right? And all of a sudden they might even feel muted where it's like everything is closing in on you, right? It really depends on the diagnosis that you're giving. Um, so, you know, the tone of voice, how you approach, how you sit next to them, all of that, all these little nuances make a big difference. And so I think it's very important to have this human to human connection. You can just how you face them, how your computer is set up, all those things make a big difference. So whenever somebody comes into the room, I walk in, I introduce who I am, and like there's a chair and I'm facing them. So yes, the computers, the ergonomics of how things are set up, it's never user friendly. It's never meant to be for human to human, for good bedside approach. But anyhow, I don't even look at the computer. I look at the computer for simply their name. And of course, there's a referral, but I ask them, even though I've already looked at the referral ahead, I've seen their imaging and I kind of know what needs to be said, but I say, hi, I'm so and so. It's nice to meet you. What brings you to see me? So I want to know from their perspective what it is what are their concerns? Because sometimes what their concerns are not what they're being referred for. So I see if there's a match. Yeah, it's quite often that doesn't align up. So, and then I say, hey, did you know, were you ever told this, and this? And if they say no, I say, well, I'm reviewing through your pictures, your scans, and this is what I'm finding. And again, depending on the diagnosis, I will change my tone, the choice of words. All of that makes a big difference. And all I want them to know, if I'm delivering some bad news, for instance, if I'm seeing somebody in there, I really think it's like a choroidal melanoma, I give space. Like there are certain scenarios where we can make the diagnosis of tumors in the eye and things like that. I give space. Like when I'm saying something and then I let them absorb and then like I say, do you want to say something? Do you have any questions? I know and I go through everything and then I give them the space to ask me. I say, do you want to bring somebody in? Right? Um, so
Like a caregiver, is that what you like
yeah,
someone
yeah,
that they've come
absolutely.
with?
Because I always encourage caregivers to come in because when you are talking about a particular diagnosis and how the visual prognosis, right? Even when the prognosis is good, you still want another pair of ears in the room to listen to, um, ask questions that the individual may not have, to provide additional resources, which we'll get into. But there's truly an art to providing care and to providing diagnoses, especially bad ones. Um, I don't know, Anna, if you want to,
Yeah, Anna
chime
was
in and
nodding.
kind
I think that's perfect. Yes.
It's been really refreshing hearing your approach, Nero. It's actually very similar how I do it. And yes, there is an art of communication. And I've been doing this for 28 years. And as a low vision optometrist, most of the patients who sit in my chair are the people with the vision loss. And I get far too many patients who sit in my chair who um, felt like they didn't have any hope. They weren't told of options. And I often say, like, I know with ophthalmologists and the retinal specialists or any of the ophthalmology specialists, um, their practices are quite overwhelming. There's so many people out there to be seen. And sometimes the ophthalmologist doesn't have the time to spend that extra time, like Nira was just mentioning how she spends that extra time with the patients. And that's where I often want to make sure I can help answer any of the questions that they have. I address some of the concerns. I've had patients who sat in my chair who said they had contemplated suicide because they thought that there was no option. They were told that they would go blind by a certain age. And then when they get to that age, they still have vision and realized they didn't actually live life to the fullest up to that point. And so the art of communication, that topic is so dear to me. Whenever I lecture to any eye care professionals, I start off with the art of communication because I find if doctors of any field, if they actually treated that patient who's in that chair in front of them as if it was their loved one or themselves, how would they want to receive the news? Just thinking that way would just tweak some of the word choices that they would use. Just like you were saying, you actually, if you know that the diagnosis might not be in favor and you know that they may have vision loss because of a condition you're going to be diagnosing, you can choose certain words to use. And sometimes I find patients are not even given the hope. They are not even told that there might be even solutions beyond glasses. And coming to see someone like myself or any of my colleagues who provide low vision rehab services, that there's often ways to maximize any of the remaining vision they have. Or if their vision is quite poor, letting them know about some of the accessible technology that's available. There's always some form of help. Now, not everyone might be open to all the technology, but at least offer it to the patients. And yeah, so it's actually been really refreshing listening to your approach. I wish many other doctors would do it the same way as yourself.
So
So
Anna, you just went
congratulations.
where I want to go. And Ed, I'm going to ask one question and then come over to you because I'd love to get your perspective on this as someone who is living with vision loss. So Anna, you just said, I wish more doctors handled things this way. So you kind of answered the question which was, do you think how you and Nero approach this is common practice? My gut is probably not. And if you agree with that, why isn't it more common in practices across Canada to handle the conversations with the level of humanity and compassion that you both are describing right now? What are the factors that are creating that different dynamic?
If I can answer, I think with the schooling, when you're in school, there's certain, like in that few years that you're going to be in school, there's so much information that needs to be taught. And for any of the eye care professionals or healthcare professionals to learn in that period of time. And sometimes you'll find, Near, I'm not sure how much time was even given with even different modalities in eye care. Like in optometry, it's 4 years of optometry in terms of the art of communication. That was never discussed. In terms of even how to even run a business was never discussed. So it's all about teaching as much as possible about the eyes, the health of the eyes, different
The
modalities and
factual
methods,
things, right?
as
The
opposed
factual
to
things. Yeah.
dealing with patients and how to convey. And if, I'd be open to doing some courses or lectures with any residents. Love to do that with you, Nero, and do the art of communication. It's
Yes.
such a
Yes,
huge,
absolutely.
huge
Absolutely.
area that isn't tapped
So
into.
I think I briefly mentioned at the beginning, in medical school, there's a little bit on delivering bad news, or we have, at UFD we have clinical skills where we go over like these kind of how to talk to patients and all that stuff. I think what you brought up, I think Ed and I kind of talked about this as we were waiting, about our healthcare system and how there's so many different levels within the healthcare system where there are many issues that are not being addressed, right? Taking primary care, for example, where family doctors are overworked, inundated with paperwork. So then you have to ask, like, where is the room coming for compassion? Because burnout is real. And we are not addressing burnout from different aspects and from a medical standpoint, right? From the healthcare team, the nursing group, the physicians of every sector that you look at. So I think we're at a point where just we're all suffocating a little bit. There's just more, as the baby boomers are coming into the healthcare system, consuming more of the healthcare system. And there's epidemics of various sorts, diabetes, the metabolic disorders. It's not just the baby boomers, right? It's younger people are getting more sick. So you have way more demand. We just can't keep up. Like the supply isn't there. And so there's a fixed number of doctors who are trying to serve an over, so like there's just too many people within the system. And so at some point, if you're really crunched for time, if you're not cognizant, right? We're all humans. We all have problems. We all come with our own baggages. So it's very easy, right? If you're not able to disconnect emotions carry over. So you're not always, because you always have your own health issues too. And so if you're sitting there and you have a very busy day, and if you're not conscious about it, and if you don't make a conscious effort, it's very easy for an interaction to go really turn sour.
Yeah, it's what you're describing is a lot of what is in the media, right? Our healthcare system is challenged with: growing population, aging population, not enough doctors entering the workforce, retirement is happening, so the younger people aren't yet ready to move into the leadership roles. Or it's a conundrum. It's a bit of a pickle we find ourselves in, and I can appreciate that your frontline services are really feeling that pinch as well. Ed, I'm curious, your diagnosis was 25 years ago. I assume that you have continued to work with a vision specialist along the way. Is that true? Like, is that a safe assumption? Because if so, what I'm curious about is the experience that Niro and Anna described is kind of what I would argue is like a best practice. I think that's what everybody would want to have when, especially at a time of diagnosis. What was your experience like back then? And have you seen changes in the healthcare system as you have moved through it on your own journey?
Yeah, so thank you, Jennifer, for the opportunity to talk about my experience navigating the healthcare system, both the high points and sadly some of the low points. Yeah, about 25 years ago, I started to notice unusual changes in my vision, and I went to see my ophthalmologist, and he said, "Oh, Ed, you're just getting old," and sent me away. And when I came back 2 years later, it was clear it was not just that I was getting old. He also said he would quarterback the effort to try and figure out what was going on with me, and he didn't do that. So needless to say, I didn't stick around with him for much longer. But that sadly is an example of the lows that I encountered initially. And I suspect things have changed a fair bit since then. But what I would say is, because I didn't have, the point I would make is, it's so important to have someone overseeing your search for a diagnosis if you have to go searching for it. And if you need referrals to other specialists, you need someone quarterbacking that. And I didn't have that, so I was kind of frantic, went all over the place, went down to the States. I'm from the States, and my family wanted me to go down there for consultations. So it was a pretty crazy time. Eventually, I did get the diagnosis, and Jennifer, as you mentioned, it's a cone dystrophy, which means I'm kind of losing my central vision, and slowly losing my central vision, but my peripheral vision should remain intact. And I want to. A cone dystrophy is a variant of retinitis pigmentosa, or RP. but I want to make clear it's not nearly as devastating a diagnosis as typical RP, and I'm sure there are people in the audience today who have experienced, loss of their eyesight at a young age, and how devastating that is. So that was kind of my initial brush with the healthcare system, or maybe collision with the healthcare system. And after that, I was seen at Hospital for Sick Kids here in Toronto in the Ocular Genetics Clinic, and got really great care there. So, what a wonderful place. Dr. Aong, who is the chief of that service, she sent my blood off several times to try and find my genetic type, because that's something we haven't talked about, is, not just getting a diagnosis, but what genetic type you have. And that can be really important. Maybe we can talk about that later. But unfortunately, they were never able to identify my genetic type. And I have aged out of sick kids. Obviously, they have a mandate to see children, not adults. So for quite a few years, I would say I had very good care from an optometrist, an experienced optometrist. As well, I had the benefit of meeting with Dr. Anna here, who provided me with really invaluable assistive technology that's made a difference in my life, and she was great. I'm just going to quickly come to the end of this journey with the healthcare system. My optometrist retired about a year ago. I saw a young, enthusiastic, somewhat overzealous optometrist. Her bedside manner was, I think, fairly sensitive, but she misdiagnosed me. She said I had the beginnings of glaucoma, and I was devastated. Because I'm losing my central vision, if I also lose my peripheral vision, that's just unbearable. The thought of it was unbearable. Turns out I don't have glaucoma. My family doctor sent me to an ophthalmologist who was very businesslike, but he was so reassuring. And so that was great. And just to round this out, about a month ago, I met with an ophthalmologist he gave me permission to use his name, Dr. Brian Bellios, and he was the first recipient of the FBC's Clinician Researcher Award. And he's trying to pick up a lot of the cases that have aged out of sick kids. As well, he's trying to help me find my genetic type. My saliva, as we speak, is winging its way to Helsinki, Finland. And he has a lovely bedside manner. He gave me the time, and I felt understood and cared for. And so it's kind of that brings us up to the present, and it's really a nice ending to what was a really rocky beginning.
Yeah, those multiple diagnoses, no matter how far apart they are, each one must feel like its own wall that you're walking into. And I have to just call out Dr. Alisi at Sick Kids, who is a good friend of Fighting Blindness Canada, as is Dr. Brian Ballio. So you're working with two of like the best out there, which is wonderful to hear. And we know that they're treasures to us, and certainly to the Canadian ecosystem of vision loss. There's a couple things that I want to tease out a little bit, and they've already started to come out here. And one of them is around the use of technology in accessing the care that you're looking for. We're a big country. Not everybody is able to just drive down the road and find their doctor, perhaps. So help me understand the role of using technology to find a doctor, build a relationship with a doctor, somehow find your way through diagnosis and treatments. And how do you find that approach if you are not maybe in an urban center? And just, also, how do you advocate for yourself if you don't have easy access to an in-person experience? I'm kind of throwing that out there to see maybe Niro and Anna, if you would like to take that. And then Ed, as a patient, curious if you've created a hybrid experience because of where you are in your journey are. Yeah.
I just want to build off of Ed's comment about where the initial, when you were told like, oh, you're just getting old, like it'll be fine. And then eventually, it wasn't fine. I think what's important from that, it's such a profound message. Trust your gut instinct. When you know your body best, and I say this to patients all the time, you know yourself best. No one else knows you better. So and this is not just about eye health, this is about anything. If you feel something is wrong, you keep advocating. If you find that first person and they don't, you're like, no, I know something is wrong. And we hear multiple stories like this, right? Where it was after the second or third doctor that they saw, somebody actually sat and listened and did the workup or the extensive workup, and then there was a diagnosis. So kudos to you, and like anyone who's on the session tonight, where if you feel like there's something missing and you want the answers, you just got to find the right person for you to sit and listen. And so that goes back to your question, Jennifer, is about how do you advocate for yourself, and how do you advocate for yourself in the instance where you don't have you may be in a remote setting and you don't have the specialist. And I think if anything COVID has taught us is the use of virtual platforms and the virtual consults, and to be able to find resources in areas where they may not be in your local setting, but we can set up virtual platforms for consultations and visits. And I don't know, Anna, if you do any virtual sessions. Definitely that's one big one. And then talk to people, like talk to your friends. The number of my patients who will kind of by word of mouth talk to their friends about their injections or whatnot, and then they end up coming to see me. I had somebody tell me like, oh, my cleaning lady told me about you. And it's such a small world, so all you have to do is ask. If you need the help, ask. And it's all about right. And if it's just keep asking until you find the information. And we also live in a world, in a very techie world, right? Like you can find a lot of information. If you're not tech savvy, find somebody who is. And again, this goes back to everything kind of boils down to communication. Ask for the help that you specifically need, find the resources, find the physicians. And sometimes it is a bit of a wait, right? Like seeing a subspecialist where there's a very particular niche, you may have to wait, but it may be worth the wait for you to get the answers that you need to get the help in terms of whether it be a diagnosis. And sometimes half the battle is just knowing what it is. There may not be a solution, but half the battle is knowing what it is. Not knowing what you're going through is very challenging. Sometimes when you're like, okay, all right, I feel a bit better. Like, information is powerful. So, but yeah, Anna, I would love to hear about, your remote sessions.
Yeah, well, I definitely agree with all of your comments. Definitely be a self-advocate. And with the tech age that we're in, on the internet, you can look and you can do Google searches to try to find information. And I get people who come and they travel from all distances. I have patients who come from North Bay, from Kingston, from Windsor. I've had somebody come from St. John's, Newfoundland to come see me, someone from Victoria, BC. I have someone from Nunavut. Because in my field, there's not too many people who actually do low vision rehab services. There's not too many low vision optometrists. That's why I actually created my mentorship program to hopefully train other eye care professionals. And I've been able to do so with some in other provinces. Because there's a lot of people who need the help. They don't know how to get the help, or they have to travel quite the distance, or they've not even heard that there's these kind of vision rehab services beyond what glasses can do. Because many patients sit in my chair and they say, well, my previous doctor said they can't make my glasses any stronger. There's ways that someone who does low vision rehab like myself, we can tweak a prescription. There's certain things that we can do first with glasses. And I always say the eyeglass part is a foundation. Then there's other aids that go beyond glasses that we can use to get someone to see better for looking at faces, TV watching, reading up close. Ed knows there's digital magnifiers that make a world of difference, which work much better than the traditional handheld for many people, because you can increase the magnification, change the contrast. But what has happened because of COVID, it actually opened up new doors and opportunities for myself. One is that one of my suppliers, they've actually formulated a kit that I could actually um, do kind of a pre-call with a patient to understand what are their vision goals. Based on their vision goals, I will actually try to see if they can if they're from a remote area or quite the distance, they can't come to Toronto to see me. I'll recommend that they've at least seen an eye doctor, an ophthalmologist or an optometrist within 6 months. If that doctor can send me the report of where their vision is, I can then, based on what they're telling me, I know which aids are most likely going to work, and we can send a kit to them, do a virtual assessment. And if there's things in the kit that work, they get to keep only the ones that work. They send everything else back. They get billed only for the ones that actually made that difference for them. And I've been able to do that for quite a few patients who just haven't been able to travel. And the other thing that we did with pivoting is whenever somebody gets some of these digital aids or aids that require a little bit more training, my staff member does virtual Zoom training calls with that person and if they can have family members there to help support them as we're doing the training visit. Never did I think that would be a possibility until COVID, and we were able to pivot in a positive way to use technology in these Zoom calls to be able to work with a patient who might not be able to come all the way to the clinic. Especially most of my patients don't see well enough for driving. They have to rely on somebody else to bring them to the office. So technology has allowed us to pivot.
So what I want to ask then, and Ed, you said a little bit here, and then Anna, you too, are there some general misconceptions that your patients have when they come to you, either for a diagnosis or post-diagnosis? And Ed, you said you thought your diagnosis meant you were going to be completely blind. And we've heard from our community that sometimes that's what people think the diagnosis means. And then they carry that with them until they can finally have a conversation where they start to uncover the reality of what they're facing. Are there certain kind of themes or are common misconceptions that you find your patients come to you with, and do you want to debunk a few of them for us right now?
Well, if I can continue,
Yeah.
one, often patients don't know that there might be help beyond traditional glasses, number one. Two, like you said, many people, especially with if they've had vision for most of their life and then they get a diagnosis, it could be macular degeneration or another condition, they may feel that they can go completely blind. So I always tell my patients with macular degeneration, it can affect their central vision. It will not affect their peripheral vision. That peripheral vision I can tap into to get them to see so they can see faces. They can do many things. Now, as long as they don't get another condition that can affect the peripheral, they will never go completely blind from macular degeneration alone. And with that also being said, some people, if they've had this long diagnosis and they were told that there's no help available for them, some people think that means don't go for another eye exam. There's nothing no one's going to be able to help me with. And for years, they're not seeing anyone to check the remaining health of their eyes, especially pressure in their eyes, making sure they don't have glaucoma like Ed, you thought you might have, because glaucoma is a silent eye disease. A patient wouldn't know in most cases that they have it, and we don't want something that could be treatable, caught in the office, that could be damaging the remaining vision be undetected until that point where it actually is causing more permanent damage. So still really important to go see their ophthalmologist or their regular optometrist just to check their health of the eyes regularly. Really important.
Thanks, Anna. Make some really good points there. Nero, you were kind of nodding
Yeah,
along.
I'm nodding to
What's
because
your
I'm like,
perspective?
yeah, I totally agree. There's so many conditions that are preventable. there are many things that there's reversible and irreversible blindness. And there's so many nuances, little things that we can do. And Anna's touched on many of them, and things like even cataract, right? So if somebody has macular degeneration with, let's say, geographic atrophy, there's tissue thinning. So there's a scotoma, there's an area where they're not seeing, or their central vision is really bad. It's like, should we do cataract? And I say, of course you should, because they have their peripheral vision, right? And then now Anna can use like a little bit of eccentric fixation and get them to see, faces, as she said. There's a lot of potential, and I think what's beautiful about the future is there's a lot more coming. I think what was 20 years ago, where it was maybe a more doomy, gloomy diagnosis, there's a lot more hope in the future, even with stem cell therapy, not just for inherited retinal diseases, but as well for macular degeneration and degenerative retinal conditions. There's hope. And there's a lot in the pipeline. So I think it's important as well when we're providing a diagnosis. Yes, you need to be realistic, but at the same time, I think we also need to instill a little bit of hope that all isn't lost, right? Because we really don't know what the future holds. Like right now, it's a moment in time, and this is what things are. As you said, if somebody said you're going to go totally blind, and they're carrying that diagnosis with them, not fully enjoying life and embracing each moment. Whereas if you had given a little bit of hope, that path would look very different.
Yeah, listen, this is a perfect segue for where we're going to go right now. And first of all, I want to say thank you for the conversation. We're going to move to a Q&A shortly so we can take questions from our audience. And I've seen a bunch pop up, so I know there's a lot of people eager to get their question in front of you. But I think, Niro, what you just said is a perfect way for me to say, like, we believe at Fighting Blindness Canada that, investing in research is an investment in hope, because that is what's going to bring treatments, and those treatments are going to eventually lead to cures. And it is really important that people understand that that's the role that we play in Canada. And we've got international relationships to make sure that we are investing in the most promising world-class research. And that's actually started to show, some real success over the last few years, with Luxturna being one of the drugs that is now allowing for some restorative of vision to people with a particular gene in RP. And so there is this really interesting and exciting time for the vision sector, and we're right in the middle of that. And so thank you for talking about hope, because I do think it's really important. It's certainly an important part of what we do. What I want to do right now is give the panelists a bit of a break. And we're going to take this moment to really celebrate the recent winner of one of our early career investigator research awards. So it ties us back to the research that we do and why it's so important. So in addition to bringing experiences like this to our community, one of the things that we're very, very key to in Canada is, as the largest charitable funder of innovative research, it's making sure that we continue to make that possible. And so with the generosity of our donors, Fighting Blindness Canada recently held a grant competition. And this year, the focus was on early career researchers, or early career investigators, like Dr. Brian Ballios was many years ago. And it is our pleasure to announce that Dr. Sharon Q is one of our Clinician Scientist Emerging Leader Award winners. Dr. Q is also our first optometry awardee. So that is a perfect tie-in for the conversations we're having. We've got a short video from Dr. Q. She's charming, incredibly committed to her career, and absolutely loves what she's doing. And she wanted to explain a little bit about the research that she's doing, and a shout out to all of you for making the grant to her possible.
Hi, I'm Dr. Sharon Q. I am a residency-trained optometrist and also a full-time PhD student here at the University of Waterloo. Corneal diseases are one of the top 5 reasons of blindness globally. The goal of my research is to improve the current design of scleral lenses. Scleral lenses are an important non-invasive treatment option for patients with corneal diseases. What we do is, when we insert a scleral lens, we put a layer of saline in the lens The saline layer not only keeps the eye moist at all times, but also fills in any hills or valleys of an irregular corneal surface. In a way, it's giving patients a new cornea to see through. The question I'm trying to answer here is, do scleral lenses with customized limbo zone design offer a better fit, enhance patient comfort, and maintain the health of the cornea in the long term compared to conventional scleral lenses that we currently use? With the support of this research grant, we're able to design the next generation of scleral lenses. I would not be able to do this without you. Thank you, Fighting Blindness Canada, for your support.
Right. I had an opportunity to spend some time with Dr. Q, and she was just beyond thrilled for the recognition with this grant, and was super proud of the work she was doing. So we're thrilled that she's now part of the Fighting Blindness Canada family, and you'll probably hear from her more over the years. But now I'm excited to continue the conversation and open it up for the questions from our audience. I want to move to our Ask and Answer segment, and that is brought to you by the Dealey Group and Roche Canada. Thank you to our corporate sponsors for making this possible. One of the questions we have here, it has a strong medical component, but I think it also touches on the importance of having a strong doctor-patient relationship, and that built of trust that you've talked about. This question is from Judith, who says, I have glaucoma and it has been managed with a surgery as I'm allergic to drops. My surgeon didn't know if that was the preservative drops or the medicine. She really suffered and had a hard time convincing their doctor that she was not imagining pain. She said she refuses to put drops in her eyes now. And the question is, do many patients have this problem? Is this something that you encounter often enough that you're comfortable speaking to it now?
Yeah, I can tell you that I think side effects, toxicity of the conjunctival and corneal surface is a very common side effect seen in glaucoma drops. And complete allergy, although rare, can happen where they just can't tolerate any of the drops. So now I can't comment to the full breadth of the glaucoma practice and the drops available, but there are more and more preservative-free drops. So if you're using the preservative-free and you're still having irritation, then it's the drug itself that there may be allergies. Having said that, glaucoma field itself is also transforming tremendously. There's microinvasive surgery, lots of different stents. There's also lasers. So the armamentarium for treatment of glaucoma is also has bloomed quite a bit in the last 5 years, I would even say. Again, not my field, so I can't speak to the full breadth, but it's definitely changing and there's lots more options.
Thank you for that. Yeah, it's helpful to understand that the different factors involved and providing some clarity on what Judith may be able to pursue with her doctor. So thank you. A second question is, here's how it's written. I've been diagnosed with glaucoma for a few years now. I feel lost and unable to see. I would love to get direction as to how to navigate the medical system for much needed help. Is there a low vision specialist in the interior of BC, in particular Kelowna, or lower mainland Vancouver area?
If this person actually reaches out to my office, I was fortunate to speak at the BC Optometry Conference in April this year, and I did meet an optometrist who is, if I'm not mistaken, she was in the Kelowna area and was doing low vision. But by all means, if they reach out to my office, if you share that contact information with them, I'm happy to then relay some information. One of the people that I just did the mentorship, who did my mentorship program, he's in BC. So I think he's in, if I'm not mistaken, it was Surrey area, but I'm more than happy to reach out to my colleagues to see who might be doing low vision in that area. The other option is you can always reach out to the BC Association of Optometrists. For us here in Ontario, when we're actually, or even the College of Optometry in BC, we have to actually document every time we're renewing our license and our association dues. If we have a specialty or an area of practice that we focus on, they may have actually a directory of other doctors that they can actually provide this person as well. And this would be in any of the provinces, another route to be able to at least find out, is anyone providing low vision services in their specific province that they may live in, or in their city or a nearby city that they live close to.
Thank you, Dr. Anna. I don't know if Niro, you would have anything else to add to that?
No, I think Anna's the expert in
Yeah,
this.
the expert on it.
I'll
But you were
defer to
nodding.
that.
I wanted to make sure you
Yeah.
answered. But you know what? There's two comments here, and it's not so much a question, but I want to read it out because I think what you just answered, Anna, is perhaps these other two comments are getting even more at the frustration that people have with the process. So one person is saying the process is way too complicated. I am so angry at the continued complication of this process. To what end? So I think that was just someone who's expressing like their frustration and navigating what is a rather complex healthcare system. And I think I'll take a moment to acknowledge, the privilege of someone who was born here, has relationships, has a network. English is my first language. Like, I can only imagine how complicated it is for people who don't come with access to all those resources. So it is complicated enough for those who are supposed to be able to navigate it. And then we layer on extra things, and this is daunting, and at a time where people are carrying a lot of fear.
If I can add to that,
Yeah.
as my care professional myself, and I've been practicing for 28 years, I too am very frustrated with the system. In Ontario, we're fortunate to have a program called the Assistive Devices Program to offer some financial assistance to some vision aids. And with that, the caveat is that the ADP program, Assistive Devices Program, they have not increased their fees for these vision aids in over 24 years. I'm using a stale dated program where there is some great technology, some great aids, but the fee schedule hasn't increased. We were supposed to meet with the government in March of 2020, end of March. Everybody knows what happened middle of March, and basically our lives got turned upside down. That meeting that we were supposed to have at the end of March of 2020 has yet to be rescheduled 4.5 years later, where it was going to be us discussing again the fee schedule to see if they can actually add certain things. And so, and I know in Ontario, one of the things that's often said is, well, you're lucky to have the ADP program because some provinces don't have any funding whatsoever. And that's not how we should be choosing how we're trying to get these solutions to our patients, where you're letting somebody know from one province, well, unfortunately, you don't even have any coverage. And Ontario, yes, you have coverage, but it's a very stale dated program. So I would wish that it would be more up to date. And after 28 years of working, hopefully before I ever retire, we will see changes to the system. So I can definitely echo that frustration from my end, that I wish I could actually provide more for my patients when especially finances is often an issue. So
Given the implication of vision and overall quality of life and other aspects, it translates into the piece that we didn't really get a chance to cover, mental well-being, right? Significantly. Like, I had a patient earlier this week talking about how frustrated she is and she feels depressed because nobody's addressing her concerns, because she's having balance issues and other things. She's got arthritis and vision problem with macular degeneration. So we sat there and talked about, what we can do together, making referrals, right? Low vision assessments, all of that. But you're telling me this hasn't been addressed. Talk about inflation, right? Our population is aging. More people have visual impairment. And, the cost of living is ridiculous, never mind. And this hasn't been adjusted for 20 years.
the fee schedule has not been updated.
Like, I think we need to not only advocate on behalf of our patients, but like for services and for subsidies, because we're talking about most of our seniors, right? Like, what is their income bracket? how are they able to afford these extra devices? Because, right, like there's one aspect is having somebody listen to your concerns, and then there may be devices that you can use, but you can't afford. So I think there's a lot of room for advocacy and developing or a subsidy or programs where, we need to figure out a way to do better, because, vision impacts so many different aspects of your life. And this is
I
also a
agree.
good time point, like the National Eye Strategy Bill, C-284, like coming to see that. And I mean, we're making strides, we're making progress, which is good, but we need to keep doing better.
Yeah, I'm glad that you brought that up. And for anyone who's not aware, for the last few years, a collective of a lot of different vision organizations across Canada have come together to advocate for the passing of a bill that would help us establish Canada's first national eye care strategy. So it's still shocking to me that in 2024, this is something we've been having to fight for. But the great news is that it just received royal assent a couple of weeks ago. And so now we have permission to create a national eye care strategy that will help address some of the issues we've talked to tonight. It's about making sure that there's more professionals being trained and brought into the marketplace so that more Canadians have easier access to healthcare professionals. It's about educating Canadians on the value of vision health and making sure that there's regular preventative checkups. So education accessibility is an important part. There's another component that we're really excited about, which is innovative research for treatments and cures, research for rehab. There is a huge need for this in our landscape, especially as you've touched on with the aging population. So there's more and more boomers that are moving into the segment of well, they're hitting over 65. Eyesight is starting to drop, and that population is growing about 3 to 4% every 5 years. And so it's, this is becoming a system that is already overburdened, is now having to manage the need for even more care. And this is not an easy place to be. And that was part of the reason why I wanted to talk about technology and stuff too, because there's even a lot of Canadians that are snowbirds, and yet they need still the treatment when they're south, right? So how do they stay in touch with their doctors along the way? I think there's a question here. I actually just want to close the loop on that. We've got some information. It was the question about a low vision specialist in Kelowna. And what I have here is Vision Loss Rehab Center, or Vision Loss Rehab Canada, has certified low vision therapists, and there is an office in Kelowna that offers free low vision assessments. So again, Vision Loss Rehabilitation Canada does have practices across Canada, and they deal with the rehab of vision loss. So whether it's an acquired brain injury, it's a stroke, or it's someone who's losing their eyesight due to eye disease, it's helping people navigate their way through their day-to-day. And that leads me to another question that we have here. And this person is saying, I have AMD, wet in the left eye, and I get injections. They also have GA, that's geographic atrophy, in the same eye. They heard that CNIB does visual rehab, but they're not sure what they do. What are the pros and cons of using CNIB versus a low vision specialist like Dr. Juricic?
Oh, well, that's a great question. So I'm glad that question was brought up. I do a lot of work with the CNIB, or the Vision Loss Rehab, here in Ontario and in Toronto, and it's a collaborative effort. So when I see a patient, or whenever somebody is asking this kind of question, know that by seeing a low vision rehab optometrist or ophthalmologist, there are some ophthalmologists who do low vision rehab work as well, we are going to be that foundational piece, because we can actually do the refraction, see how we can first tweak that prescription. At Vision Loss Rehab with the CNIB, they have some therapists who do some of the assessments. It's often with the simplified magnifiers, maybe some telescopes, but you need to have an updated refraction. That is the key. I always actually stress that whenever I lecture. Really, really important, because that is a building block of everything else. If I don't have an up-to-date prescription for that person, anything that I show, it only gets them to one level. In terms of being able to maybe meet that driving requirement, sometimes it's tweaking that prescription with use of prisms, special prisms. We can tweak it, or we can actually determine if somebody might be able to even drive with a new bioptic driving program. And so you'd have to see someone who is a low vision optometrist or ophthalmologist. And then there are actually certain things that the CNIB and Vision Loss Rehab do in conjunction with some of the high-tech services, do independent living assessments where they can go into their homes, teach them how to use that technology. So it's actually a collaborative effort where we all have certain things that we're good at and certain things that the vision loss rehab centers are really good at. It's actually a collaboration. And that's where I always say it's a teamwork between the ophthalmologist, the optometrist, low vision rehab optometrists and ophthalmologists, the CNIB, or even, Fighting Blindness Canada. I'm often referring my patients to get the information that you send out every single month in terms of what's happening with vision research. So there's a lot of different elements, and that's really important that patients and people who have vision loss know it's not just one route, it's actually possibly a few different branches to be able to get the most for their vision. And so that way they can live independently. And, this whole conversation about depression, I always say statistics are out there. If you have vision loss, you're at 6 times increased risk of being depressed. So even being able to connect with someone who might be a psychologist, like Ed was a practicing psychologist, or a psychiatrist, someone who may even be able to relate in that field, or it could be even a social worker, or support groups, other people have vision loss, that's huge, because sometimes I find that my patients, their family members don't understand what's going on, especially if that family member was kind of the key role in that family. They used to do all the cooking, baking, or they had such a key role. It could be the father, the mother. From the outside, they look very much the same. They might have aged a bit, but they have no clue how this person is seeing and how they may be feeling. And I find that these are the individuals, if they can actually meet other people with vision loss, it sometimes helps. So that way they don't have to explain what their vision is like, but they can at least have that social interaction, which is so huge. And we saw that so much after COVID and during COVID, how important that social interaction with other people really is. And that's how we can keep them also possibly out of that depressive state. So really important to include that aspect.
Thank you for that. I know that was a message that we had agreed we really wanted to get out in this conversation around the importance of peer support and mental health, and helping people feel like they're not in this alone, and that they can turn to others for that kind of compassion and that support, and it's a role that we play, and we'd like to play more of a role in it. But I think you're hitting on something that is certainly becoming a more important topic for people in the vision loss community. And it's unfortunately the question I have to wrap up on, because we're really coming to the end, and yet I still have some stuff I have to cover, and we didn't even get to all the questions. Because there was a lot more that we could have gone on with, which I'll note to self for this topic next time, and we'll add an extra 15 minutes or 30 minutes to let this have more of a fulsome conversation. But I want to do a bit of a wrap up on what I think we and everyone can take away today. And it's definitely that even though we're in a new era of medicine, right, and there's a lot of technologies available to us for diagnosis and for treatments and even accessing a professional, there's still such a long way to go to make sure that all Canadians have access to a vision specialist and the latest treatment, and that they know what's available to them, right? So they feel empowered and they're really armed to be able to walk into your offices and ask the questions that are going to get them the answers that they need. There's a long way to go, but we've certainly also come a long way. In 50 years, we've been advocating for the vision loss community, and that is a conversation that we had today that would have not even been, I think, possible a few years ago, to bringing in the concept of like the importance of caregivers, the importance of mental health, and really acknowledging the role that technology is playing. As you said, Niro, like pandemic taught us a lot. And that silver lining was that this thing that we have in front of us can be such an uber connector, and to maximize that potential, I think is really important for everybody. So we have a long way to go, but Fighting Blindness Canada is, committed to being part of that and continuing to invest in the most promising vision research and support our community with education and connection and conversations like we're having today. I really honor that you've been with us. Thank you so much, Dr. Glassman, Dr. Juricic, and Dr. Sivachandran. Thank you for joining us.
Thank you.
Thank you for having me.
Thank you so much for the opportunity. And yeah, any time for this conversation.
Well, we'll
Next time
take
in
you up on that.
Yeah.
I agree with that statement. It's a very important conversation. So thank you so much for actually doing this evening. It's been wonderful. Thank you.
It's been a pleasure. Thank you. Okay, as we wrap up here, there's a few last items I want to leave you with. We're going to invite you to join us again for the third and last Accelerate Vision Health Series episode on Thursday, February 20th, 2025. This is the final episode, and it is going to be on vision health, innovation, and discovery. I also want to take a moment to say another thank you to all of our donors who made tonight possible, including our event sponsors, Dealey Group, Roche Canada, Amgen Canada, Bayer, Heathbridge Capital Management, and the Bachner Eye Institute. Thank you also to our community supporters. If you would like to support our vision research and education series, you can donate using the QR code on the screen or at fightingblindness.ca. And finally, you are ending tonight's episode with a special video feature spotlighting a community member, which I hope you enjoy. Thank you and enjoy the video, and enjoy the rest of your evening. Good night.
I may not be able to see the world as I used to, but I'm still living a life on my own terms. As an immigrant to Canada over 50 years ago, I've always been independent, but in 2020, I was driving one evening. I realized there was something wrong. My vision was fading. The diagnosis of age-related macular degeneration was devastating. My first reaction was, where do I go from here? I had to make some tough adjustments. I lost my driver's license. It felt like I was losing my independence. We felt that it might be a good time to downsize, to move from a multi-level house to a condo in the city. With the help of my wife and my family, it turned out to be a blessing. Here, I'm closer to my doctors, my community, and the support that I require. I've learned to accept my conditions and focus on what I can control. Now I'm helping to spread the awareness. The one thing that I would like others to know, don't neglect your health. Stay informed, keep up with your doctor's appointments, and don't be afraid to ask for help. Your eyes are the gateway to everything. Take care of them.